on the West Coast in Vancouver, and now I've landed somewhere in the middle, which is in Ottawa, the capital city. It's on the border between Ontario and Quebec. One of the interesting things about Ottawa is it has a canal. It has a canal running through the town. This is in the back, the green spires are the Parliament buildings, and the Rideau Canal runs through much of the city. And for better or for worse, in a few weeks, it's going to look like this, where it becomes the Rideau Canal Skateway. It's billed as the largest skating rink in the world, and over the couple of months that it's open, it's tens of thousands of people come and skate, and it's 8 kilometers long, and it's quite fun. So it's something to look forward to in the winter. And given the kind of winter we're going to have, it's good to have outdoor things to look forward to these days. So we got that coming to us. But today I'm going to talk about audit and feedback. The goal, I think, is to give you a little bit of the basic background, although Marina did a good job with that. Talk about these 15 suggestions that we published in 2016 to summarize some of the best practices that we could recognize, and then we'll have this discussion afterwards, which will be great. So when we're talking about feedback specifically, we know that there are lots of different kinds of potential feedback that healthcare providers can get. Some of it is systematic, some of it is just irregular. It can come from a variety of different sources. It can come in verbal or written format. It can be about very specific aspects of practice or very general, overall 360-degree aspects of practice. The kind that we're focusing on today primarily is what I generally refer to as outcome-specific feedback. That's where the literature has been, and it involves, as the definition shows, a summary of a particular aspect of clinical performance over time, over a certain period of time, and then providing that back to practitioners or teams or healthcare organizations. Why do we want to focus on audit and feedback interventions particularly? In the last 10 years or so, there's been a fair bit of focus from a research perspective on how to improve audit and feedback. Well, there's lots to recommend audit and feedback interventions in general. They're often fairly flexible, fairly light touch interventions. The data are available, increasingly available from all sorts of different sources. Very often people are looking for feedback. And audit and feedback can nicely be often paired with other intervention components. So it doesn't have to be a single intervention, but rather it can be part of a suite of interventions. So there's lots to recommend it, including the fact, as Marina alluded to, that it works. We know that audit and feedback from a large systematic review that Noah Ivers did of 140 trials, that across a huge range of different fields, different disciplines, different settings, that feedback interventions generally work. The effect size is small, but there's a fairly wide variability where some actually work very well. And for example, there's another systematic review looking at using audit and feedback for test ordering specifically, and the mean reduction there with audit and feedback interventions was something like more like 22%. So a potential in a lot of different settings for it to be useful. The bad news is that, as Marina alluded to, we don't seem to be getting any better at it over time, and that there really is a huge variation in effectiveness. So we sort of have a sense, at least over the last few years, that feedback works generally. We're just not quite sure how it works. And that's what we've been working on in Ottawa to try to explain that a little bit. I thought I'd give an example of one fairly large-scale effort to provide audit and feedback, and use that as a jumping-off point. So this was a study that was reported in 2005 in JAMA. It's a Canadian study. It was focused on using hospital administrative data to improve the quality of cardiac care using cardiac indicators. So what this group did was they collected data from all 77 hospitals in Quebec and compiled data on 12 outcomes that had been previously agreed to be worthwhile and relevant to the quality of cardiac care. They designed these nice displays. These are this displays 4 of the 12 outcomes that they provided to hospitals, 2 histograms per outcome. They sent this feedback display, essentially 3 pages of feedback, to the directors of services at the different hospitals. Feedback was sent once based on data from the previous year. So as you look at this feedback, and when I do this talk in sort of live format, I get people to sort of stick up their hands and tell me whether they think this is a pretty reasonable approach to giving feedback, and whether it might be expected to be at least somewhat successful. I don't think I'll do that in the Zoom situation here, but I'll just tell you up front that this intervention did not work at all. Didn't move the needle at all in terms of any of the indicators. And then once you know that, you might well be tempted to start generating hypotheses about why it didn't work. Perhaps it's not the right indicators. Perhaps it's too many indicators. Perhaps it's because they sent the feedback to the directors of services and not the individual practitioners who were involved in the actually doing the activities, doing the behaviors. Maybe it's because the feedback was sent only once. Maybe it was the data were too old. It was last year. So there's lots of ideas, lots of hypotheses that come up about why this particular kind of intervention, well-resourced, well done, published in a large impact journal, why it didn't seem to work. So that's where I think we've been in the last few years. We know that feedback works, but not how it works. And so that's what led to a project where we started interviewing theory experts, feedback theory experts. So healthcare is not the only place that thinks about feedback. There are lots of different academic disciplines that think about feedback. And so we went out and talked to 28 theory experts from a wide range of different areas and different disciplines. And when you talk to these different people, you really get a sense that there are a wide range of perspectives that you can bring to the study of feedback. You can think of feedback simply as a cognitive challenge, and your goal is just to make it easier for people to understand. You can think about it as a way to direct attention to the thing that you're interested in, away from all the other 1,000 things that providers have to think about in the run of a day. It can be a motivator or a demotivator. It can be a reflection of self-identity. If you're providing bad feedback to someone who thinks they're doing a good job, it can be a learning education tool, et cetera, et cetera. So there's a lot of different ways in which you can think about feedback, and each one of these different perspectives sort of implies different mechanisms by which feedback interventions might be more or less effective. But as we were having these really in-depth discussions with theory experts, it became clear that there was a number of ideas that were relatively uncontroversial, but that still weren't being implemented in healthcare. And so we sort of saw these as the sort of low-hanging fruit issues that could be used to improve health feedback interventions now. And so that's what led to this paper, the Annals paper that was published in 2016, where we try to distill some of these lessons into 15 suggestions. And I'm not going to be able to go through each one in detail, but I do want to give a general sense of what the 15 recommendations are about. The suggestions 1 to 3 are all about the sort of nature of the action you're hoping people will engage in once seeing your feedback. So recommending actions that are consistent with established goals and priorities. Recommending actions that have room to improve and under the control of the recipient, which is often overlooked. And then recommending actions that are relatively specific, as opposed to just leaving it up to the healthcare provider what they should do with the data and whether they should act or not. I'm going to unpack a couple of them a little bit further. So this first one about recommending actions consistent with established goals and priorities. Well, does this first example, is it a good example of that? Well, in this case, it's described in the paper that there was a fairly substantial consensus process that had gone through sort of all across Canada to identify these 12 indicators. And so it was generally agreed by experts that these were 12 good indicators of quality of cardiac care. So from the way I have been thinking about these things, that's a good example of aligning with established priorities, but not necessarily aligning with goals. And I distinguish between goals and priorities because priorities are external, priorities are organizational. Goals are internal. Goals are what an individual would like to do to improve or to change or not to change. So this example is one where it's clearly aligned with organizational priorities that they've organized with the consensus process, but not necessarily with internal goals. And there is a huge literature from psychology about what happens when people set a goal and how they go about achieving those goals. Now, it's not always feasible or easy to get healthcare providers to adopt goals that are in line with yours, but it's something we're thinking about in a lot of cases. What about recommending actions that are under recipients' control? Again, this is a sort of blow up of one of the indicators of that first example that I showed. Is the action that you're hoping the recipient to engage in, is that under his or her control? Well, keep in mind, here, this indicator is the percentage of patients filling a prescription for beta blockers after discharge. Remember that this feedback was given to the director of services in the hospitals. They weren't given to the individual providers. And even so, even if it were given to the individual providers, the indicator is more about what the patient's doing, not necessarily what the physician is doing, right? So there's a couple of steps away from the ideal adhering to this notion of providing feedback that is under, where the action is under the recipient's control. A series of suggestions on the kind of data that should be ideally available for feedback. So providing feedback multiple times everyone agrees is important. You need to close that feedback loop. Providing feedback as soon as possible, but not so frequently that you don't show any difference, any change from one set of feedback to the next. Providing individual rather than general data, and choosing comparators that reinforce the desired behavior change. I'm going to unpack that one a little bit, just because it's we spend a lot of time when I'm helping other groups design their feedback to think about comparators. Using comparators that reinforce the desired behavior change is often challenging, but in general, we've been sort of pushing this idea of choosing an aspirational benchmark. So this is an example from a paper that was trying to use feedback to reduce overprescription of benzodiazepines. And as you can see, it's a very simple graph. This is the percentage of long-acting benzodiazepines that you've been prescribing. This is what the average is, and this is what a group of that's been identified as best practice, might be the top 10% performers or something like that, has managed to do. And you can imagine that if this hadn't been provided, if the feedback only consisted of you and the average, then the feedback recipient might look at this and say, well, I'm doing better than average. I don't need to do anything. And so that's why the notion of the aspirational benchmark that says, even though I'm better than average, I've still got more to go. There's still an action I need to take. And so that's the notion of choosing comparators that reinforce the desired behavior. In this case, the average probably doesn't do that, but the best practice or aspirational goal does. Suggestions 8 to 10 are about the display of the feedback. That's a wide field because there's certainly a large literature on how to present complex information effectively, and so that people understand it and it teaches people and all of those kinds of things. We sort of distilled some of these lessons into these 3 suggestions, closely linking the visual display and the summary message. So in the UK, for example, there are these national clinical audits that can often be 100-page documents where the summary is at the front and the data are buried at page 60. And so the notion is that putting these sort of self-supportive visual display and summary messages together in the same display is a good idea. Providing feedback in more than one way, in terms of text, in terms of numbers, in terms of graphs, in terms of spoken word. Doing it more than one way is generally considered a useful way to convey complex information. And then this notion of minimizing extraneous cognitive load will unpack a little bit more. It covers a wide range, but I like to think about it in terms of, white space and trying to limit the amount of information you are trying to get across at once. And so this is an example where we're trying to, this is an example of the supportive messages where the summary message and the numbers are all presented together. So this is a graph. This is a numeric summary of what the graph says. Again, these are percentages and written statements about what the overall message is that should be taken from the feedback. So minimizing extraneous cognitive load. As I say, this is a huge area, and potentially you could talk for an extensive period of time about it. I like to think about it in this way. I don't know if people know the Edward Tufte book, The Visual Display of Quantitative Information. It's a great book. It's really interesting. It's very, it's sort of handcrafted in terms of providing lots of examples of good graphing and bad graphing techniques. And this is a display that he really likes. He's described it as like the best example he can think of providing good data. And what it is it's a depiction of Napoleon's advance into Russia in 1812 and 1813. And when the campaign started, the French army was 400,000 strong. It was the largest army that had been assembled at that point. And over the course of the year, you can see that at various points, various battles happened to whittle down the army. various points, certain chunks of the army go off and get demolished or not and return to the main base. They run into particular problems when crossing rivers. When they start to retreat, the temperature goes down, and during the course of various river crossings and bad weather and a number of other things that befalls this disastrous campaign, they return with 10,000 people when they started with 400,000. The thing that Tufte loves about this graph is that it is a great example of what he says, a graph that repays careful examination. It has a huge range of variables that it's addressing, and if you spend some time with it and you really study it, you can learn a lot. And that is an example of what he considers to be a really great graph. I would argue that this is not the kind of thing we should be looking for when we're designing feedback displays. I think we should not be asking our provider or whoever our feedback recipients are to spend an enormous amount of time and effort to unpack what is a really lovely and elegant display. I think this is much more like what we should be providing to people. It's something that conveys a simple message and encourages the person to perhaps explore further, and yes, absolutely provide additional backup data to support this initial message. But that initial message should be very simple, because providers are busy. This is whatever you're providing feedback on is one of many priorities they have in the run of the day, and anything you can do to convey a simple message that suggests that, oh, I need to do something, that's what we should be aiming for. And then finally, these last 5 suggestions are about how to go about delivering the intervention, the feedback intervention. So addressing barriers to use, providing short messages followed by additional detail. So make sure you provide that simple graph first, but provide in the background a way for people to explore further for those who want to. Addressing the credibility of the information, making sure people understand that the data are good. Preventing defensive reactions and constructing feedback through social interactions. I'm going to unpack a little bit more. So the 2 most common responses to feedback that is negative, feedback that suggests I'm not doing what I should be doing, are, do I believe these data? Or, my patients are different and therefore these data are right and should be right, right? And so these are 2 sort of hurdles as a feedback provider you have to get over first in order to get people to really engage with the data. So defensive reactions can just lead to ignoring the data, and I'm going to continue on with what I do. Either I don't believe them or I do believe them, but there's a good reason for it. And so we can do things to start to overcome those defensive reactions, things like avoiding feedback that's consistently negative or punitive, having people engage with other feedback recipients and to have them discuss and either in a sort of facilitated way or just in a group setting also helps people get over the initial negative reaction and potentially learn something more from the feedback. And then this notion again of social construction of feedback is a useful tool in our arsenal. Providing feedback in a social setting can encourage people to think about their own performance before receiving the feedback even. Getting the recipients to work with the feedback, to engage with it, to think about it, to compare to others, all of that rather than simply getting an email and I'll pay attention to it or not. Providing opportunities to provide feedback about the feedback is also a useful task. So making sure that the recipients understand that this is an iterative process. This is a process that is going to improve over time. And having facilitation and dialogues with feedback, all these kinds of tools that we can do to encourage that people spend a little bit of time with the feedback and get over that initial hump and start thinking about what they might do with the feedback. And this is just a slide based on a project that we're doing right now, where we're evaluating whether a series of audit and feedback activities in critical care are adhering to these 15 suggestions, essentially. We've unpacked them a little bit. And just to give you a sense, I mean, the things that are in red were rated as clearly not adhering to the recommendation or the suggestion. The things that are in gray are situations where it's not clear or it's not reported whether they're adhering to the suggestion. And you can see there is a lot of red or gray in this bar chart, and suggests there's still a lot of improvement we can do in terms of designing feedback interventions that adhere to these sort of basic suggestions. So in general, this is a sort of very active research process, and we think that the sort of general key areas that we need to push forward on are, for example, testing hypotheses about which kinds of feedback are more effective, need to be tested at scale. When we did those interviews, we generated like about 300 hypotheses, not just the 15. We generated 300 of them. And so we need to do a lot of work in order to start to test some of these things. We need to understand how to help people choose where they should put their intervention resources. You can provide feedback on way more indicators than people can take in. And so how do you choose, I should be providing feedback on this as opposed to these other things? And so helping with the audit side, helping to decide where the resources will benefit us is worthwhile and something we need to push forward. And then finally, we need to start thinking about all these different mechanisms that stem from those 7 or 8 different perspectives that we talked about, and try to explain audit and feedback interventions theoretically. And so Ben Brown's theory is one effort to do that. So that's a very quick sort of summary of the 15 suggestions. I'm looking forward to our discussion and people's questions. And I'll stop there, and thank you very much.